education in Anhui, China, where he received his bachelor degree of medicine in 2011 and his master degree in medicine in 2014. Most of his research work up until this time was centered around pathways that protected or led to the loss of bone marrow mesenchymal stem cells in animal models. Frank commenced his PhD studies with our group in 2016 on various aspects of primary aldosteronism, a condition which is now known to be a common, potentially curable cause of human hypertension. His PhD was accepted without changes earlier this year. Unfortunately for us, Frank has returned to his hometown and is now a resident physician in the Department of Cardiovascular Medicine, the first affiliated hospital of Anhui Medical University in China. His current research directions are to explore the activity of the renin-angiotensin-aldosterone system in patients with hypertension, including primary aldosteronism or heart failure in different clinical scenarios. I'd have to say it's been an extreme pleasure and privilege being Frank's supervisor, and I do look forward to the opportunity when he can come and visit us again and work together as colleagues. So congratulations, Frank, and I'll let you give your presentation.
Thank you. Thank you, Michael. And thank you for having me today. Okay, my thesis title is the Histopathological, Biochemical, and Genetic Characterization of Different Types of Primary Aldosteronism, including validation of a new angiotensin assay. So firstly, I will give a very brief general introduction. So as an important endocrine glands, the adrenal glands consist of an outer cortex and an inner medulla. And the adrenal cortex is histologically comprised of 3 different zones: zona glomerulosa, also known as ZG, which is responsible for producing mineralocorticoid, and zona fasciculata, ZF cells, which is responsible for producing glucocorticoid, and zona radicularis. So in the normal conditions, the production of aldosterone is regulated by the renin-angiotensin-aldosterone system, while the production of cortisol is regulated by the ACTH. Because the key enzyme associated with aldosterone and cortisol productions are restricted to the exclusive zones within the adrenal cortex, so aldosterone tends to be produced only in ZG, while the cortisol production mainly happens in ZF. This slide shows the process of the RAS activation, and this process begins with the conversion of angiotensinogen to the angiotensin 1 by renin's enzymatic cleavage action. Angiotensin 1 is then converted by the angiotensin converting enzyme into angiotensin 2, which can directly stimulate adrenal ZG cells and activate the production of aldosterone. On the other hand, consequent volume expansion and excessive angiotensin 2 generation can also cause negative feedback to the kidney and inhibit renal renin release, thereby stopping the activation of the RAS. Primary aldosteronism is now considered the most common cause of endocrine hypertension. In PA, the overproduction of aldosterone caused by hyperplasia and/or adenoma of one or both adrenal glands will lead to excessive salt and water retention, increased potassium excretion, and target organ damage. In the patients with PA, because aldo is overproduced, so release of renin and its downstream generation of angiotensin 2 are inhibited. This is also why an increased value of the aldo-renin ratio can be used as a potential indicator for the patients with primary aldosteronism. So the diagnostic workup of primary aldosteronism includes 3 stages: the screening for PA by the aldo-renin ratio test, confirmatory testing usually using the photocortisone separation test, and the determining the PA subtype. So the first project of my PhD study is about to comparing the 2 different aldosterone assay. And we also proposed the aldosterone mass spec specific threshold values for PA screening and PA confirmatory testing. So the accurate measurement of plasma aldosterone is very important because it involved in all 3 stages of the PA diagnostic workup. And currently, the plasma aldose concentration is mostly often measured by the immunoassay. But concerns have been raised about the weakness of this antibody immunoassay. For example, the antibody specificity is very low. Some interfering substance, such as structurally related steroids, will cause cross-action, thereby with causing the overestimation of the results. In 2009, our center reported that we can use the mass spec to measure the plasma aldosterone, which was highly accurate and reproducible. Subsequent analysis within our laboratory has revealed a lower value of the plasma aldo measured by this approach when compared to the immunoassay. So this result suggests that when undertaking screening and confirmatory testing for PA, reduction in current threshold value for the aldo-running ratio and FST, which are both established using the aldo immunoassay, would be necessary if the aldo is measured by the mass spec. So the aims of this project is to compare aldosterone measurement by the chemiluminescent immunoassay with the mass spec and evaluate the performance of our proposed mass spec specific cutoffs for PA screening and confirmatory testing. For this project, we first recruited 311 patients, and we compared their plasma aldo concentrations by the two aldo assays. We also compared the two aldosterone running ratios when the aldosterone is measured by the two different assays. The second cohort, including the 41 patients who were undergoing the fludrocortisone separation testing in our center, we also measured their plasma aldo concentration by using the two different assays. So the result one is that we can see that in the total of the 475 samples, the two aldosterone assays revealed an around 28% higher estimation of median plasma aldo concentration value by the chemiluminescent immunoassay than by the mass spec assay. And in this slide, we can see the correlations of the aldo results by the two assays. And there is a good linear relationship between the testing results of the two aldosterone assay. In this slide, we can see that the performance of the two aldosterone threshold values for the FST. The current day 4 aldo plasma aldo concentration threshold value for FST when aldo is measured by chemiluminescent immunoassay is 165. And when we put the 165 into the aldo regression equation, which is yield from the comparison of these two aldosterone assay, we can get a new aldo mass spec threshold value for FST, that is 133. And we also investigate the performance of these two threshold values in FST. As we can see in the table, among the total of 41 patients who completed the FST, 37 demonstrated consistent FST results, and whereas 4 showed inconsistent results. And in these 4 patients, 3 tends to be correct if we use the mass spec to measure aldo, and 1 tends to correct if the cutoff is used by the chemiluminescent immunoassay cutoff. And in these slides, we can see the performance of the two aldo running ratio threshold values for PA screening. The current aldo running ratio threshold value for PA screening is 17 if the aldo is measured by the chemiluminescent immunoassay. And when we put the 70 into the aldo running ratio regression equation, we get a 55 as a cutoff for the aldo running ratio when plasma aldosterone is measured by the mass spec. And among the 17 patients whose FST results are consistent, which means that their diagnosis is confident, 4 patients showed false screening results. And in these 4 patients, 1 patient's one patient's aldosterone ratio results seems to be correct if the plasma aldosterone is measured by the mass spec. So the conclusions of this project is that, firstly, our results provide preliminary evidence supporting the satisfactory performance of proposed cutoffs for PA diagnostic workup specific for the measurement of plasma aldo concentration by mass spec. Secondly, there was no difference in sensitivity or specificity between the current aldo-Rennie ratio cutoffs when a plasma aldo is measured by the chemiluminescent assay or by the mass spec, or between the FST day 4 plasma aldo cutoffs when the plasma aldo is measured by the two assays. This data emphasized the need of the adjustment of the current threshold values for PA screening and confirmatory testing if aldosterone is measured by the mass spec. The second project of my PhD study is about the validation of a novel equilibrium angiotensin II assay and to investigate the use of this new assay in the diagnosis of the primary aldosteronism. So, because the RAS is the dynamic cascade involving multiple angiotensin processing enzymes and peptides, peripheral levels of which are very low, it was traditionally thought that accurate measurement of these unstable angiotensin peptides was extremely difficult. This is also why, although angiotensin II is the direct regulator of adrenal aldosterone production, we only measure renin as a surrogate markers for angiotensin II in PA screening and confirmatory testing. Besides, in addition, many factors has been reported can cause false positive or false negative, can affect renin and aldosterone, thereby causing false positive and false negative aldo-renin ratio results. Because, and additionally, the aldo-renin ratio is mathematically more dependent on renin than aldosterone, especially when renin levels are very low, as in patients with PA. Small changes of renin can result in large changes in the aldo-renin ratio. And the renin is not the direct regulator of the aldosterone, angiotensin II is. So can we find out another indicator to replace renin in PA screening test? Recently, a novel RAS equilibrium analysis has been reported to be able to quantify different angiotensin metabolites simultaneously from one blood sample. The principle of this RAS equilibrium assay is to establish an ex vivo equilibrium states of the RAS by incubating the pre-stored frozen serum under controlled conditions for 1 hour without blocking any angiotensin processing enzymes. The final angiotensin levels are determined by the activity of all soluble angiotensin processing enzymes present in tested samples and can be maintained by equal formation and degradation rates for each peptide in the status of the RAS equilibrium. So there is a new tool for PA screening. The aldo-angiotensin II ratio maybe can be used in PA screening. The rationale of this concept is that angiotensin II, rather than renin, is the direct regulator of adrenal aldosterone production. Hence, measuring angiotensin II should provide a more meaningful assessment than renin in any test that seeks to determine whether the adrenal is producing aldosterone autonomously of the RAS. The aims of the project 2 is to design to provide an initial assessment of the validity of this novel assay by assessing changes of the measurements under conditions known to affect the RAS. And the second aim is to the aldosterone angiotensin II ratio was also calculated and compared with the current aldo-renin ratio under the above conditions. So we recruited 78 patients who were undergoing the fludrocortisone suppression testing. We connected blood before and after the fludrocortisone suppression testing, and in the before and after the testing, we collected the samples in the morning twice, one in recumbent position and another in upright position. The results In this table, we can see that PA patients has a much lower equilibrium angiotensin II levels than non-PA patients. And in non-PA patients, when patients change their position from recumbent to upright, their equilibrium angiotensin II showed an increase. And also in non-PA patients, after taking fludrocortisone for 5 days, their equilibrium angiotensin II was decreased when compared to the baseline. We also investigated the performance of the renin and the equilibrium angiotensin II assay when at the lower concentrations during the FST. The functional sensitivity for the renin concentration, renin activity, and the equilibrium angiotensin II assay were 2, 0.2, and 2 picomole per liter respectively. And we can see that in PA patients, we measured 224 samples. 111 samples showed there has a renin concentration below the functional sensitivity, whereas for the equilibrium angiotensin II, there are only 6 samples which is the equilibrium angiotensin II results were below the functional sensitivity of equilibrium angiotensin II assay. And in this table, we also can see the correlations of the renin and equilibrium angiotensin results during the FST. So in the first 2 red frame, we can see that equilibrium angiotensin II results correlated closely with both renin concentration and renin activity. This is the scatter plot picture of the renin concentration correlated with equilibrium angiotensin II and the renin activity correlated with equilibrium angiotensin II. Finally, we also observed the correlation between the aldo-renin ratio with the aldo-angiotensin II ratio. The aldo-renin ratio here was measured by 2 renin assays. The first is the renin concentration, the second one is the renin activity. They're both correlated very well with the aldo-angiotensin II ratio. So the conclusion of the project 2 is that it indicated that there are good consistency and close correlations between equilibrium angiotensin II and renin in non-PA and PA patients in response to an assumption of upright posture and to fludrocortisone administration and oral salt loading. But the equilibrium angiotensin II assay has a better analytical sensitivity than renin concentration and renin activity assays at no concentrations. The second is that the aldosterone angiotensin II ratio also shows close correlation with the aldo-renin ratio, and it would now seem reasonable to assess whether it demonstrates superior performance in situations that are known to associate it with the false positive or false negative aldo-renin ratio results. So the project 3 is that we investigate the effects of the ramipril and Assay inhibitor on the aldo-renin ratio and the aldosterone-angiotensin II ratio in patients with primary aldosteronism. So when patients are receiving the Assay inhibitors, for example, ramipril, it will block the conversion of angiotensin I to angiotensin II. The decrease of the angiotensin II will cause the decreased production of the aldosterone. So when, on the other hand, the decrease of angiotensin II will also relieve the negative feedback of angiotensin II on renal renin release and will stimulate renal renin release from the kidney. So if we measure the aldo-renin ratio in patients receiving Assay inhibitors, we really will get a false negative aldo-renin ratio results. But this is maybe not the case for the aldosterone-angiotensin II ratio because the aldosterone and the angiotensin II both decline in this situation. The hypothesis of this project is that the aldosterone-angiotensin II ratio may be superior to the current aldo-renin ratio in PA screening test among hypertensive patients receiving Assay inhibitors. So the aim is to investigate whether aldoangiotensin 2 ratio can be used as a screening test for PA, and whether aldoangiotensin 2 ratio is superior to the current aldorenin ratio in detecting patients with PA receiving ramipril treatment. So we recruited 13 patients who just completed the AVS examination in our center. We choose patients in this stage because firstly, the diagnosis of their PA had been confirmed. And at this stage, these patients' current antihypertensive medication didn't include any other drugs that are known to affect the aldorenin ratio. There are totally 3 time points for sample collection. First is a baseline, before using the ramipril. The second collection time point is after taking ramipril for 2 weeks, and we collect the samples in the morning, 2 hours after patient taking the last dose of ramipril. And the third time point for sample collection is 26 hours after taking ramipril. That is the day after day 14. There are totally 2 cohorts of patients. The first one is used to doing the ROC analysis to predict the optimal aldorenin ratio and aldoangiotensin 2 cutoffs for PA screening. We recruited 16 PA patients and 14 non-PA patients. The second cohort is includes 30 patients who received the ramipril treatment. In the first cohort, the ROC analysis results showed that the aldorenin ratio and aldoangiotensin 2 ratio, the area under the ROC curve of these 3 ratio, all greater than the area under the reference line, which indicates that they all can be used as a screening test for PA. And the ROC analysis also revealed the optimal cutoffs for these 3 ratios in PA screening. Importantly, the aldorenin ratio, the cutoff yield from this ROC analysis is 53.9, which is very close to 55 that we reported previously. And for the aldoangiotensin 2 ratio, the optimal cutoff is 8.3. In this table, we can find the changes of the measured parameters before and after ramipril treatment. For the renin, we can see that after taking the ramipril for 2 weeks, it showed a slight increase. And for the angiotensin 2, after taking ramipril, it decreased significantly after taking the ramipril. And we also measured the surrogate of the angiotensin converting enzyme activity. We use the equivalent angiotensin 2 divided by the equivalent angiotensin 1. And we can see that the activity of the angiotensin converting enzyme also decreased significantly after taking the ramipril. In this table, we compared the correlations of the 3 ratios and among their denominators before and after ramipril, and they all showed close correlations during this study. And in this figure, we can see that the influence of the ramipril on the aldorenin ratio and the aldoangiotensin 2 ratio. So in the figure A, we can see that there are 4 patients showed false negative results with their aldorenin ratio results below 53.9 on the day 14. And there are 1 patient still showed false negative results on the day 15. And for the aldosterone-renin ratio, when renin is measured by the renin activity, there are 3 patients showed false negative results after taking ramipril, with 2 patients still showed false negative results on visit 3, that is day 15. But for the aldoangiotensin 2 ratio, no patients shows false negative or false positive results. And this is some details of the 4 patients whose aldosterone ratio shows false negative results during the study. So the conclusion of this project is that when aldosterone was measured by mass spec, the predicted PA screening cutoff for the aldosterone ratio and aldoangiotensin 2 ratio were 53.9, 495.9, and 8.3 respectively. Secondly, although the aldo concentration didn't change significantly after taking ramipril for 2 weeks, the changes of renin concentration, renin activity, equivalent angiotensin 1 and 2 were consistent with the drug's effect on angiotensin converting enzyme. Finally, unlike the aldo-renin ratio, which can be affected by the Assay inhibitors causing false negative screening results, the aldo-angiotensin 2 ratio seems to be superior in detected PA among subjects receiving Assay inhibitors. The last project is to summarizing the biochemical, histopathological, and genetic characterization of posture responsive and unresponsive aldosterone-producing adenomers. So the subtypes of primary aldosteronism: unilateral aldosterone-producing adenoma and bilateral adrenal hyperplasia are the 2 major subtypes of PA, accounting approximately 30% and 16% of all PA cases. And besides above differentiation based on laterality, PA can also be divided into angiotensin 2 responsive and unresponsive forms according to the responsiveness of aldosterone to angiotensin 2 infusion or upright posture. Posture responsive defined as a rise in plasma aldosterone concentration of at least 15% 2 or 3 hours after the assumption of upright posture above the basal level following overnight recumbency. Among patients with PA, aldosterone has been observed to demonstrate normal responsiveness to upright posture in those with angiotensin 2 responsive forms, which include angiotensin 2 responsive APA and most cases of bilateral adrenal hyperplasia. In contrast, in the angiotensin 2 unresponsive forms, which include angiotensin 2 unresponsive APA and familial hyperaldosteronism type 1, aldosterone demonstrates a lack of responsiveness to upright posture and even a fall. And this slide shows the reported mechanism of the increase of aldosterone to upright posture. Further comparisons conducted by our center in later 1890s revealed that the posture unresponsive APA were predominantly composed of adrenal ZF-like cells and were associated with elevated urinary levels of hybrid steroids, that is 18-hydroxycortisone and 18-oxycortisone. In contrast, posture-responsive APAs mainly consisted of adrenal ZG-like or ZG-ZF mixed cells and were associated with normal levels of hybrid steroids. This slide shows the somatic mutations in APA. Recent studies have shown that the somatic mutations in KCNG5 and CACNA1D, ATP-A11, and ATP2B3 are present in more than 19% of sporadic APAs. And the KCNG5 is a channel is the potassium channel, and the CACNA1D is a calcium channel. And because these 4 genes are involved in encoding ion channels in adrenal cell membranes, mutations with them will result in dysfunctional cellular ion transport, which eventually leads to a rise in intracellular calcium ion levels, which in turn activates the aldosterone synthase express and the subsequent aldosterone production. So the aims of the project is to compare clinical, biochemical, histopathological, and genetic differences between the posture responsive and the posture unresponsive APAs. This is the flowchart of the study design, and and the method part. First, we doing the hematoxylin Elson staining of for each tumor, and the second we also do the immunohistochemical staining of each tumor, and the intensivity of the CYP11B2 and the CYP17A1 expression was scored by the IHC score, and we also measured the hybrid steroid levels by using the mass spec. And finally, we extracted the DNAs from the tumors and detected the somatic gene mutations by using Zeng sequencing and the next generation sequencing. The clinical and biochemical characters. In this table, we can see that the posture unresponsive APA patients had a higher plasma concentrations of recombinant aldo and recombinant cortisone than posture responsive APA patients. And regarding the hybrid steroids, the posture unresponsive APA patients also showed higher levels of these two hybrid steroids than posture responsive APA patients. And finally, we can see that the posture unresponsive APA patients had a larger tumor than the patients of the posture responsive APA patients. And the gene sequencing results, we can see that of 40 studied APA patients, 73 were found to have aldosterone driving somatic mutations such as KCNG5, CACA1ID, and ATP-A1, A1, and ATP2B3. And this includes 5 previously unreported mutations, 3 in calcium channel and 2 in ATP1A1. Notably, we can see that 64.7% of posture responsive APAs patients carried calcium mutations, whereas 56.5% of posture unresponsive APAs harbored potassium mutations in KCNG5. And this is the pictures of the immunohistochemical staining and the HE staining. We can see that the posture responsive APA patients showed a higher intensity in CYP11B2, but a lower intensity in CYP17A1 staining. And the most posture responsive APA patients, we can see that their tumor will consist of ZG cells. In contrast, the posture unresponsive APA tumor, they also showed a higher intensity in CYP1 in both CYP11B2 and CYP17A1. And different to the patients with posture responsive APA, their tumor were mostly comprised of the ZF-like cells. And in this one, we can see the comparisons of the IHC scores in different categories. First, we can see that the IHC score was not different in CYP11B2 between the posture unresponsive and responsive APA patients, but posture unresponsive patients showed a higher IHC scores in CYP17 than posture responsive APA patients. Secondly, we can see that the ZF-like tumors also shows higher CYP17A1 intensity than ZG and all ZG-ZF mixed tumors. And finally, we can see that the tumor with the harbored KCNG5 mutations had a higher IHC score in CYP17A1 than tumors carry calcium channel mutation or ATP-A1. And this one, we can see that the cell composition in different categories. As I have mentioned before, posture unresponsive APA patients had a higher composition of ZF-like cells. And in the tumors with KCNG5 mutations, their tumor also composed mostly by the ZF-like cells. And in this slide, we can see the hybrid steroid levels in different categories. Firstly, the posture unresponsive APA patients had significantly higher levels of hybrid steroids than posture responsive patients, and especially in the 18 oxocortisone. And in the second one, figures, we can see that the ZF-like tumors had a significantly higher 18 oxocortisones than ZG-like tumor or ZG-ZF-like mixed tumor. And in the third figure, we can see that the tumor with KCNG5 mutations had a significantly higher levels of the hybrid steroids than the tumors with calcium channel mutation or with the ATP-AL1A mutations. So, summary, the posture-unresponsive APAs lack responsiveness of aldo to upright posture, have higher levels of recombinant aldo and cortisone, have higher levels of hybrid steroids, are large in nodular size, show greater separation of aldo secretion from the contralateral unaffected adrenal, and are more often composed of ZF-like cells, demonstrate a strong expression of CYP17A1, and are associated with predominantly KCNG5 mutations. In contrast, posture-responsive APAs show normal responsiveness of aldo to upright posture and have lower levels of hybrid steroids and are smaller in nodular size, are more often composed of ZG-like or ZG-ZF mixed cells, and are associated with predominantly calcium channel mutations. The conclusion of this project is the excessive production of hybrid steroids in posture-unresponsive APAs may be related to their ZF-like composition, resulting in strong expression of CYP17A1, in addition to somatic gene mutation, driving expression of aldosterone synthesis, thereby allowing production of cortisone, which acts as the substrate for the aldosterone synthesis generated hybrid steroids. Okay, I would like to thank again to my supervisors, Professor Michael Stowers and Dr. Martin Worley, for the huge help they provided to me in the last 4 years. Thank you.